Our next speaker is Dr. Kristin Mekeel. Dr. Mekeel is one of our abdominal transplant surgeons extraordinaire. She is our primary surgeon for the live donor kidney transplant program, as well as she does liver transplant, and hopefully in the future we're going to be doing live donor liver transplants as well, so she'll be a live donor transplant surgeon. We are very happy and excited to have Dr. Mekeel here presenting to us today on kidney and liver transplant surgeries, surgical considerations, and Dr. Mekeel.
For those of you who don't know me, I'm a transplant surgeon here, kidney, pancreas, and liver transplants. For those of you who do know me, and I know a lot of people are here from the 11th floor, I really do want to say that I think the 11th floor has become a really great transplant unit. I really have a great time working with all of you, and I really appreciate the hard work you put into taking care of our patients. Transplant patients are not an easy group of patients. Lots of complications. There's sick patients coming into the operation, and they really are a challenge to take care of. And I do think it requires a special group of people, you know, surgeons, physicians, nurses, coordinators, everybody. And we have all that here, and that's why our patients do well and things work out well. So I'm going to first talk about kidney and pancreas transplantation. We'll see if we get to pancreas, but mostly I'm going to talk about kidney transplantation, living donor, and then I have a brief video of a robotic donor so that you guys can get a little bit of an idea of what it looks like to have robotic surgery. So first of all, just a little bit about why we do kidney transplants. You know, as most of you know, kidney transplants, the indication are patients who have end-stage renal disease. This is chronic kidney disease, stage 5, and then usually a glomerular filtration rate of less than 20. That's when you can get listed for a kidney transplant. As most of you also probably know, you do not have to be on dialysis to get a kidney transplant. We do kidney transplants preemptively before patients go on dialysis. In a perfect world, that would be the obvious answer, that you get sick enough to need a kidney transplant, and we do a kidney transplant before you ended up on dialysis, but of course we don't have enough kidneys, so it's not possible. In the United States, just like a lot of other disease processes right now, the most common causes of kidney disease are diabetes mellitus and hypertension. Diabetes is getting bigger and bigger every year. So right now it's encompassing at least 25% of the kidney failure that we see, and probably getting on 40 or 50% in the future. Hypertension, glomerulonephritis, these are the patients that you see who are younger, who have IgA nephropathy, MPGN, FSGS, polycystic kidney disease, congenital abnormalities of the kidney, patients who've had kidney cancer, Alport syndrome, which is deafness and kidney failure, lupus and autoimmune diseases, and then we're seeing an increasing number of recipients of other solid organ transplants, including heart, lung, and liver, who end up with kidney failure. Unfortunately, ProGraft, for all of its wonderful things, it's made transplant what it is today, is nephrotoxic, and it's nephrotoxic over the long term. Heart and lung patients in particular are run on very high levels of ProGraft, and it's about 20 to 25% of these patients end up needing, or being eligible for a kidney transplant in their future. So contraindications, who do we not choose for kidney transplant? Anyone with active malignancy. If you've had a malignancy that's been resected and treated and you're several years out, depending on the malignancy, you could then become a kidney transplant candidate. Say a kidney cancer that was confined to the kidney, you're 2 years out, there's no evidence of any other disease, those patients would obviously be able to get a kidney transplant at that time. But active colon cancer, pancreatic cancer, that type of stuff is a no-win situation. Active infection, so an active bacterial, viral, or fungal infection. But hepatitis C, HPV, and HIV are not contraindications to transplant. HIV seems like it would be a contraindication, but the reality is a lot of our HIV patients these days are very well controlled and stable on their antiretroviral medications, and a lot of these patients do have things like polycystic kidney disease or other non-HIV related causes of the kidney transplant. It does require increased attention to immunosuppression after the transplant, but in and of itself is not a contraindication. We do have a couple patients listed right now that you guys will see come through. Severe cardiac, pulmonary, or peripheral vascular disease. Poor social support, so we do go into great detail trying to make sure that patients have families and money and everything else to take care of what's a very overwhelming life experience to have a transplant. If patients don't have the social support to have people help them after a transplant, we can't give them a transplant. Severely deconditioned people are bad transplant candidates if they can't get around, wheelchair bound, very malnourished, that type of thing are not good candidates. And then obesity. Unfortunately, obesity is a bigger problem in the transplant community, just like it is everywhere else. Right now, our BMI cutoff is 35 for transplant recipients. There are places in the country that will do up to 40, but 35 to 40 is the cutoff for most programs. So if you have renal failure, here are your options. You can either undergo hemo or peritoneal dialysis, transplant, living donor or deceased donor, or no treatment, in which you would die. There's been a lot of studies. Is this a pointer too? Oh, yes. All right. So if you look at patients who, why do we do transplant? Well, the obvious reason why we do transplant is that we want people to get off dialysis, because of course your life's going to be better if you're not on dialysis. But there's a bigger and more important reason we do transplants. For kidney transplants, patients who get a kidney transplant, despite the risks of surgery, despite the risks of immunosuppression, they actually live longer, and by years, by decades, they live longer than patients who remain on dialysis, especially a living donor transplant. And this is a graph that shows that. So our box is live donor transplant, our circle is cadaveric donor transplant, and these are people who remain on dialysis. And you can see this is from 1997. So if you have all these people starting out at the same place, you go 10 years out, you have a much higher chance of being alive 10 years out if you have a transplant than if you don't. So this is the real reason we do transplants. We are saving people's lives. So unfortunately, kidney transplant, right now we do not have enough kidneys, and this is a national problem and a really big problem in California. So as of September, there were 93,413 patients listed for a kidney transplant. It's probably up to 94,000 by now. 6,813 patients received a kidney transplants last year. So you can see we are transplanting just an actual 20% of the actual people who need transplants every year. And of those, 11,000 from deceased donors and 5,500 from living donors. So it's a huge discrepancy. We have all these people waiting and we just don't have enough organs. 4,720 people died on the wait list for kidney transplant last year. So California, we're actually in, and I'll talk a little bit more about this in livers, but in California, we have some of the longest waiting times in the country. Luckily for kidney transplants in San Diego, we're better than the rest of California. So right now in LA and Riverside and Orange County and in the San Francisco area, they are waiting 10 to 12 years for a deceased donor transplant. People aren't even being evaluated. They just sort of get listed, and then if they actually get close to the transplant, then they get them evaluated at that time. And it is why you are seeing a higher proportion of our population here are people who can afford to come down, from LA and Orange County, because our list is shorter. So, but our list also gets longer and longer every year. And when I first started here 2.5 years ago, we were telling A people, oh, it'll be just a year or two. Now we're up to 3 years. And for Bs, we're up to 5 years. I also do the pediatric transplants. We waited 3 years for a girl to get a blood type B kidney. And for the kids, we can usually transplant them within a year. So right now in San Diego, for blood type O, we're 5 years, B, 5 years, A, 3.5 years, and AB, 3 years. The reason this is that A's have the most ability to get living donors because they can get donors from A's and O's. So O's and B's have the hardest time. And O and A are the most popular blood types. ECD kidneys, and I'm going to go a little bit more into this definition in a minute or two, but ECD kidneys wait anywhere from 2.5 to 4.25 years. Oh, I didn't mean to do that. So kidney allocation, how do you get allocated a kidney? So, and again, I'll talk a little bit more about this with livers, but for kidneys right now in the United States, it's just really based on points. And you get most of your points of when you get listed for transplant. Not when you start dialysis, not when you get diagnosed with kidney disease, but when you actually are seen here at our institution and listed at our institution for transplant. Right now, if you are sensitized, so sensitized are patients who've developed antibodies to other people, and in particular antibodies, HLA antibodies. So sensitized people are people who had multiple pregnancies, multiple blood transfusions, or multiple transplants. If you have these preformed antibodies, it is more difficult to match a kidney to you. If the recipient has, the antigen to those antibodies, you will have immediate hyperacute rejection. So we can't use kidneys in some of these donors. So in the last couple of years, patients who have antibodies to greater than 80% of the population have been getting extra points. And we've actually seen an increase in the number of transplants we've done in these people, which is good. You know, these people are very hard to match kidneys to, and if they can get a match where they have the same HLA antibodies, their risk of having rejection is a lot lower, and the long-term lifespan of those kidneys is a lot higher. So it really has helped this subgroup of patients get kidneys faster. So in LA, they actually list by the time on dialysis, and then ECD allocation. So ECD stands for Extended Criteria Donor Kidneys. And extended criteria donor kidneys are kidneys that have a decreased lifespan compared to the standard criteria kidneys. So they're a special list. So just a little bit about deceased donors. This is a problem we're getting into in the United States for a lot of things in organ transplantation. But first of all, and I'll define ECD in the next category, but you can see right now standard donors are most of the donors still, ECD, but you can see this line is going down, right? So we're getting more ECD donors and more less standard donors. But in particular, look at this. So here's our 0 to 17 donors, but ages 50 to 64 and 65 to 70, they're all going up, except that one right there. So we're actually seeing an increase in the age of our donors, and we're also seeing an increase in the comorbidities of our donors. So when I first started out, it was a lot of trauma and head injuries and younger donors. You know, we're saving more trauma patients, and we're seeing, you know, organ donation talked about a lot more. So we're seeing a lot of patients who have strokes and heart attacks and other problems in their 50s, 60s, and 70s who want to donate organs. And what our job is try to find, you know, the best organs for those people to go into. So extended criteria donor kidneys, we actually use about 20% of our kidneys here are extended criteria donor. And these are kidneys that have been clearly sought out to have a 70% or a 1.7 relative risk of graft failure compared to a standard kidney. And these include all donors who have an age greater than 60, age greater than 50, who've died either from one or two of these three things: deaths from a stroke, hypertension, or creatinine greater than 1.5. So when we get the organ offer, we already know if they're ECD or not based on these criteria. So right now, the ECD kidneys, if you look at them long term, they don't do as well. So here we have ECD kidneys, and you can see 10 years, less than 30% of them are working. Where if you have a living donor kidney, 61% of them are working. But the deal is that if you are listed for an ECD kidney, that you would get the kidney transplant sooner. And so especially, and back to this slide, if you're an older patient, age greater than 60, where you'd benefit from a kidney sooner rather than a kidney that lasts longer. In particular, we're listing a lot of people recently with ages like 70 and above. These are perfect kidneys for them because they really need something that's going to last 8 years, not something that's going to last 30 years. Diabetics age over 40 because they have a very high mortality. And then anybody who's in risk of, you know, failing vascular access or something else where their death might be imminent because they just can't be dialyzed. These are all the people that we would indicate for ECD kidneys. So there is a new allocation system, and for those of you who watch the news, or in particular read the New York Times, has had this huge series of articles on it. The limitations of our current system is there's a variability in access to transplantation. There's higher than necessary discard rates. We're less likely to use the older kidneys if we have younger recipients on the top of our list. And there's a disparity among the potential graft and recipient survival. As a result, there's a big new allocation system coming, and it is complicated, so I'll just sort of narrow it down. But basically, the KDPIs, they're ranking all the kidneys based on if they're really good kidneys to really bad kidneys. 0 to 100%. 0 to 20 are the best kidneys. They then rank all the recipients. Again, good recipients, bad recipients, based on how long their expected lifespan is, from 0 to 100%. And then they rank order the candidates. What the goal is to get young kidneys into young patients and older kidneys into older patients so that the kidney and the patient have the both longest lifespan together. And it's sort of like a functional years, you know, type of thing. What are we going to get the most benefit out of? Unfortunately, it seems like a great idea, and for those of us who, you know, are tired of putting, you know, 20-year-old kidneys into 70-year-olds, but we really can't ethically or legally do anything about that, you know, it should be good. However, the older people in the United States who are on the kidney transplant waiting list think that you know, they're not going to get as good kidneys, and that they may have less of an opportunity to get kidneys and all these other things. And because of that, it hasn't actually been approved yet. So, if this happens, we won't have to rely on ECD kidneys anymore. And basically what it'll come down to is about 15 years plus or minus when you get a donor age, say the donor's 55, that'll go to recipients who are between 40 and 60, or 70. So a little bit about how we do a kidney transplant. So this is a kidney, and this is a kidney in its natural, or its native area, place. This is the inferior vena cava. You have a vein that goes to the kidney called the renal vein. This is the aorta, and you have an artery called the renal artery. And then this is the ureter. Ureters go down and connect the kidney to the bladder. Adrenal gland sits up on top of the kidney. So when we take the kidneys out, we take them out with the artery and vein, but not the big aorta or the vena cava, and then the ureter. So kidney transplant's fairly straightforward. We do not remove the native kidneys, they stay in place. For most people, they are not causing any harm, so there's no reason to take them out. If there are people who obviously they come out, polycystic kidney disease, we have to take out sometimes because of infection or size, and they get painful. And then the other reason is chronic infections. So if you had chronic infections of your kidney, we don't want to immunosuppress you with a chronic infection, so we take them out. But otherwise, they stay in place. And actually putting the kidney on the iliac vessels, I don't know exactly who thought about it, but it's really quite brilliant. The iliac blood vessels are easily accessible through the groin incision. You stay extraperitoneal, so you don't go inside the peritoneal cavity, which is helpful for recovery. And these are big, good blood vessels that are very close to the surface. In addition, the bladder is right there, so we can cut the ureter very short. So it's a really great place to put the kidney. So what we do, this is the aorta and the vena cava, common iliac artery, common iliac vein, and then it splits into the internals and the externals. Most of the time, we're putting the kidneys on the external iliac artery and vein. Every once in a while, we have to put them higher on the commons. In kids, we put them up here on the aorta and vena cava. And it's pretty straightforward. We do end-to-side anastomoses. We take the end of the renal artery, make a hole in the iliac artery, and just sew the end, the end to the hole. And it works great. And again, if any of you actually want to come and watch a kidney transplant or watch a donor, please let me know. Elvie and I can get a list and everything else. But the living donors we're doing at least a couple times a month, so it would be great. It's pretty neat to do a kidney transplant. You sew it all together, you release the clamps, blood flows back through the kidney again, and it's great. It's sort of this pale, fleshy color, and all of a sudden it pinks up and starts pulsating and becomes firm and makes urine. It's a really fun thing to be able to do. So after we do the vascular anastomoses, then we sew the kidney to the bladder. So we take the ureter. The ureter has to be cut very short. When the ureter is in its native body, it gets blood supply from the whole entire body. So it gets blood supply from the kidney, from the lumbar vessels, from the aorta, from the gonadal vessels, and from the bladder. When we take it out and put it into the recipient, it's only getting blood supply from the kidney. So when you don't have good blood supply to the ureter, it can get two complications. It can necrose and leak urine all over the place, or it can cause scar tissue, which is called a ureteral stricture. And that scar tissue would need to be ballooned or sometimes fixed. So because of that, you really want to preserve good blood supply to the ureter, and we want to cut it very short. And again, that's the other reason that the iliac fossa is a great place to put it, because the bladder's right there. And again, it's not rocket science. We make a hole in the bladder, we cut the ureter to the right length, and then we just sew the bladder to the ureter. Here at UCSD, we do use stents in every one of our ureters. And a stent is just a very small piece of plastic tubing, looks like a straw, but it's a little more malleable and it curls up in the kidney. The stents decrease the risk of both of those complications from the ureter from 7 to 10% to 3 to 5%. And we rarely see urine leaks anymore now that we've been using a stent, and the stricture rate's gone way down. So it is not great for the patients to have a cystoscopy a month after surgery and have the stent removed, but it's much better than having these complications. So this is what a kidney looks like. You can see nice and pretty and shiny and pink. That's the ureter right there, and this is part of the aorta right there. Can't really see the blood vessels. This is a kidney after we put it in. This is actually put up on the common iliac artery, which is right here. That's the external iliac artery right there. That's the vein right here, and that's the iliac vein is right there. So you can clearly see this anastomosis right here, where we sewed the kidney together, two arteries to this kidney, and then the vein coming down there. And you can see how it's nice and pink. So it looks better on my thing than yours. So a little bit about how much urine should be produced. I think this is always anxiety for people when we take out a deceased donor kidney and then they don't make any urine, but it's actually okay. So after transplant, for deceased donors, it is very variable how much urine they make. So some of them are going to make a ton of urine right away. Some of them may take up to a month. I've actually seen 3 months before they be made enough urine to get off of dialysis. So over 50% of deceased donor kidney transplants do have delayed function that require dialysis. As long as you have an ultrasound that shows good blood flow to the kidney, you just have to wait it out. There's nothing you can do, improving blood pressure, giving diuretics, all these things, they really don't help. You just have to sort of give it time for it to decide it wants to work again. Living donors is the opposite. So living donor kidneys should be making urine out of the operating room. As a surgeon, I should be very concerned if I have a patient in the PACU who's not making urine after living donor kidney transplant. Every once in a while, we'll see people who are really hypotensive during the surgery or had bleeding or something else that don't make a lot of urine right away. But by and large, that should be, that's like 1% to 2%. They should be making urine and a lot of urine right out of the operating room. And for all kidney transplants, if they're making great urine and then stop all of a sudden, you should let the doctors know. So if it's a deceased donor and it was making super urine and then just stops, that's something to really worry about. But if it wasn't ever making urine and isn't making urine, then that's okay. So a little bit about the surgical complications. The worst thing that can happen after a kidney transplant surgically is that you have thrombosis of the vessels. Thrombosis is about a 1% to 2% risk. It is higher in living donors because of the small caliber of the blood vessels. Thrombosis also is a higher risk for actually really thin patients because you have to sort of jimmy the kidney in there and you can put extra pressure on it trying to close the fascia. Really fat patients because the fat sort of lays on top of it. And then in particular patients with hypercoagulable states. So anybody with lupus anticoagulant, any of the other hypercoagulable states we have to be very careful with around the time of transplant. Thrombosis is usually a pretty clear diagnosis. The patients do have a lot of pain because of swelling of the graft. They're not making any urine. They're tachycardic. They don't look good. So it's usually pretty clear, when that's happening. Unfortunately, the only thing to do for thrombosis is you have to go do a nephrectomy and the kidney's a loss. And it's clearly a bad thing whenever it happens. Bleeding, we end up transfusing about 15% to 20% of our kidney transplant recipients because they're all anemic baseline because of their renal disease. Actual bleeding that needs to be reoperated on is a pretty low risk, of about 3% to 5%. You would see blood in the drain, tachycardia, hypotension, etc. Would be indications for bleeding. Urine leak and stricture, I already sort of touched on. The risk is about 3% to 5%. Urine leak, we leave drains in right now in most of our patients that you'd see urine in the drain. You'd send it and had an elevated drain creatinine. And it is something that you should see within the first days to weeks after the transplant surgery. Most of the time we do need to fix this surgically, but if it's a very small leak, we can stent fully and drain it, and it can get better without reoperation. Stricture is a long-term complication, like 6 weeks to even years after transplant. These days we treat it like a lot of coronary artery disease, where we put a percutaneous nephrostomy tube in and then balloon it, and then put a stent across it. A lot of times we can make it better with just successive ballooning and stenting, but sometimes we do need to reoperate to fix it. Lymphocele, there are a ton of lymph nodes and lymph vessels that lie on the iliac blood vessels. So we try not to injure them during the dissection, but if they are injured, they can leak lymph. Lymph in and of itself is not a harmful fluid, but as it accumulates around the kidney, you get like a little balloon around the kidney and you can compress the kidney. That needs to be removed, usually with percutaneous drainage, and then if it keeps reaccumulating, we do what's called a peritoneal window. So we actually open the peritoneum, let that lymph fluid drain into the peritoneum, and then it gets reabsorbed by the peritoneum. Actually reoperating on lymphoceles is about a 3% risk. The risk of a lymphocele is about 5% to 7%. Wound infection, you guys have seen those before, and of course obesity increases the risk of wound infections quite a bit. Hernia, and then arterial or venous stenosis is actually pretty rare but can happen in kidney transplant. So the other medical complications, so you guys take care of these patients every day. These are a sick group of patients. Anybody who's been on dialysis for a couple of years has a huge increased risk of atherosclerotic disease. They're diabetic, they're hypertensive, they have poor heart function. They've been on dialysis. So, the risk of major cardiac events, and, we do a very careful cardiac workup before they come in. Everybody gets a stress test. Anybody who has an abnormal stress test, gets a cath. But, things can still get past us. So, major cardiac event, stroke, a DVT and a PE are sort of the big any complications from high-risk groups of patients. Rejection. So rejection can happen anything from a couple days to years after kidney transplant. We do use induction, and I think Mike talked to you guys earlier, so you know what I'm talking about, induction with thymoglobulin. So since the thymoglobulin, we haven't seen a lot of cellular rejection. And that's the T-cell mediated, not as dramatic, rejection that can happen right after the transplant. For those of you who took care of our patients, last year when we weren't using as much thymoglobulin on the living donors, we were having a little bit of a spate of acute rejection that seems to have gotten better with the induction. Humor rejection is something, and most cellular rejection can be treated with, Solumedrol and thymo. Humor rejection is the one we worry about more. So this is antibody-mediated rejection. So this is if you have an antibody to your donor and then that antibody attacks your kidney. You can't have the antibody before you have the kidney transplant, or you can have a new antibody that forms immediately after the kidney transplant. This is a more aggressive rejection. This is rejection where you can lose function of the kidney, and the only way to treat it is to get the antibodies out of the blood. So getting the antibodies out of the blood is why we do plasmapheresis. So plasmapheresis, basically dialyzes the antibodies out of the blood, binds the antibodies out of the blood and takes them out. We also use IVIG, so that's an intravenous immunoglobulin that binds antibodies and takes them out of circulation. And the other thing that we've started using is these monoclonal antibodies. So they have these monoclonal antibodies that are two different parts of the immune system. And the ones we're using for rejection right now, or for humor rejection, target the B cells. And so they're monoclonal antibodies against the B cells and the plasma cells that help inhibit the production of antibody. And so usually once we see humor rejection, these patients are going to be in the hospital quite a while, getting these treatments and everything else before we let them go home. Luckily, we've had a couple of these lately that have been treated and have done great long term. So the treatment does work once we recognize what it is. And last thing is infection, and you guys have seen all the infections. Pneumonias, urinary tract infections, C. diff, all these patients are more susceptible to these infections because of the immunosuppression. And in the liver slide, I have a slide of when the infections all show up that we'll look at that time. So long-term outcomes, so how do these patients do long-term? So this graph just looks at, this is expected remaining lifetimes. So when you're 0-14, you're expected to have 70 years of remaining lifetime. But look, if you have a transplant, all of a sudden that goes down to 50 years. If you're on dialysis and you're 0-14 and you don't get a transplant, you have less than 20 years to live. And you can see as this goes on and on, eventually we all get to the same spot, but for all these people, transplant makes a huge difference. But it doesn't get you all the way up to normal. So long-term outcomes, just to look at this again, but I think that this is an important slide because we are sort of failing here in transplant, right? We've gotten transplants to last really great for a year. They're lasting pretty well at 5 years. But, and you guys see these patients too. Second transplant, third transplant. We're talking about fourth transplants. These transplants aren't lasting forever. And we really are struggling as a community in transplant to figure out why. Some people think it's chronic prograft toxicity that kills the kidneys over time. Whether or not it's a chronic low-grade immune reaction that kills the kidneys over time. But for whatever reason, they're not really lasting long-term. And I think this is going to be the next new push in transplant research and everything else is to try to figure out, great, we get you a kidney transplant, but we want it to be a 30-year transplant, not a 10-year transplant. Now, hopefully, if you read, all the news and everything, we'll be able to, in 10 years or so, just take out somebody's, stem cells, put them on a scaffolding and grow them a new kidney. But, we're not quite there yet. The other thing that they are doing combined bone marrow kidney transplants at Stanford with some success. So we'll see where that research goes, but you basically bone marrow, the donor's bone marrow, and at the same time you get a kidney transplant, create a chimera in the recipient who's half one person, half the other, and then you wouldn't need immunosuppression. And they're actually getting to the point where this is, it's stuff that's been talked about for a long time, but the Stanford data is getting to the point where this may be a reality. Now, they're only doing really well-matched living donors right now, so how this would translate into the deceased donor world, we don't know. But in small groups of patients, they've had good results. So living kidney donation, you can see from all the data I just presented, living kidney donation is the clear answer to all the problems that we're having, right? It is, you don't have to wait on the waiting list, you get a kidney transplant that lasts years longer than the deceased donor transplants, and we can plan the surgery when you're in good shape and everything else. Right now, 44% of kidney transplants in the US are living donors. Compared to deceased donation, they last 4 to 6 years longer on average. The transplants can be scheduled, and then you also have more donor information, less chance of the transmission of malignancy, infectious disease, and other problems. So the downside is, of course, you have to take a healthy person and put them through an operation. So a little bit about how we select donors. Donor selection and donor monitoring is something that we take very, very seriously. And in particular, we don't want to use donors who either have kidney disease or have the potential to have kidney disease in the future, because we wouldn't want to leave them with one kidney when they were going to have problems. So high blood pressure is a big risk factor for long-term for kidney disease, but it's usually patients who have long-term out-of-control blood pressure that develop kidney disease. So hypertension is okay if they are controlled on a single medication. Obesity, right now we're using donors with BMIs less than 32. Some programs will do up to 35, but of course obese donors are at a risk for diabetes, metabolic syndrome, other problems long term. So, and also the surgeries are just much more difficult and they have an increased risk of complications. So that's why we're pretty strict about obesity. If you have a GFR, that should say less than 80. So if you have a low GFR in your kidney, if we took out one of your kidneys, you may drift down to chronic kidney disease. Proteinuria or hematuria would both be indications of problems with your native kidneys. So we wouldn't want to use those donors. Diabetes is pretty much a complete contraindication. If you are a diabetic, we will not use you as a kidney donor. We have a little bit of a wash for patients who may be pre-diabetic, like what if you're a really healthy person but you have a hemoglobin A1C is 6.1. Those are the things that we sort of struggle with as a team trying to decide what these donors' risks are. The actual risks are probably very low, but we don't know for sure, and of course we don't want to take any risks with the donor, so it's a difficult thing. Stone disease, anybody can get a kidney stone if you get dehydrated or something else. If you have one kidney stone, you're not prone to kidney stones, and you don't have a lot of stones in your kidneys, we can use you for a donor. If there are a lot of stones or you have a metabolic stone disease, then you're not a candidate. It would be bad to remove one kidney and then get a big stone in your remaining kidney and have the kidney lose function. Malignancy, again, we've talked about that with the other things, active infection, and then psychosocial. People get into all sorts of weird reasons why they want to donate kidneys, and a lot of them, can cause problems for the donors and recipients afterwards. So our donors all go through social work evaluation, and then if necessary, a psychiatry evaluation, and then they're seen by an independent donor advocate who is not connected with the transplant program and is just there to really, make sure that they're comfortable going ahead with the donation and that they understand what they're getting into. So safety of living donation, are we condemning a bunch of people to an increased risk of death and dialysis in the future? The data we have right now says probably not. This is a JAMA paper from 2010. It looked through 80,000 donors. They had 25 deaths in 80,000 donors, and these were within 3 months after the donation, and they did include things suicides and car accidents. So the risk is about 3.1 in 10,000, probably about 1 to 2 in 10,000 if you take out the people who died of unrelated things. If you look at the rate of death for lap chole, it's about 0.18. So 0.03% to 18% or to 0.18% is still pretty low. And compared to an age-matched cohort, there was no increase in mortality at 6 years. But that's not a long follow-up. The longer follow-up, this is a New England Journal paper. This is the University of Minnesota, which has a very robust and busy kidney transplant program. They had 4,000 donors that were age-matched to a control cohort. They did not see an increase in hypertension or renal failure, and this is going out 14 or 15 years as the median of data. And these patients actually reported an increased quality of life compared to the norms. And again, we're taking happy patients, who aren't sick, which is probably why they're happier and they live longer. But it still is very encouraging that we're not hurting these patients by taking their kidney out. So it appears that the short and long-term risk of donation is low. What I tell patients is that we don't actually know what we're doing to people when they get into their 70s and 80s, and that may be where we see problems in the future of kidney donation. What happens when you donate your kidney when you're 30 and you're 80? But there are studies in patients who've had nephrectomies for non-cancerous reasons that suggest that you do just fine with one kidney as well. So risk of complications is actually pretty low for living donation, 5% overall, 3.5% of these are minor, infection, swelling, wound infection, constipation, temporary numbness or neuropathy from positioning. But 1.5% of these are major, and these include a 0.9% risk of conversion to open. This is usually because of bleeding and a need for a blood transfusion. 0.5% risk of reoperation, and that includes things like damage to the bowel or spleen or something else where you need to go back in and fix it. Pregnancy may be the sort of one thing, and we talk about how to counsel patients on pregnancy all the time. if you are a young woman and you want to donate your kidney, but you also want to have another child or, have a child, what the risks are. And there does appear to be a slightly increased risk for preeclampsia and early birth for patients who undergo pregnancy after donating a kidney. The study compares two different comparison groups. They look at just controlled norms where the risk wasn't that different, but then they looked at patients who donated kidney after pregnancy versus before pregnancy, and there really was a difference there. And mostly it was preeclampsia was the big thing. So what we recommend right now, we don't absolutely prohibit people who want to have babies from donating. We do give this information, as part of the counseling, and we do want them to wait 1 year on either end. So if you just had a baby, you need to wait 1 year to donate. If you're going to have a baby, or if you want to have a baby, you have to wait 1 year afterwards to do so. And so far, we haven't had any problems in our patient population. We do get a whole bunch of people, though, who end up pregnant when they're coming in for the donor evaluation, which I don't quite understand. And luckily they've all been happy about it too, so it's never a good phone call to make. Back in the day when living donor first started, donors were done open, and it was a mess. For any of you guys remember taking care of these people, it was a huge incision. It went underneath the rib cage. Sometimes they took out the bottom portion of the rib. I mean, the donors were just in torturous pain for days after the surgery. And my career in transplant really just dovetailed. Laparoscopic was just getting started, and so when I was a medical student, I took care of these patients, and it was a huge operation. It is really something that only a parent would do for a child, not something you necessarily do for your best friend. It was a big deal. So minimally invasive surgery has really changed the world of kidney donation. Patients recover faster, they're in less pain, and it's gotten much better. The two minimally invasive surgery, laparoscopy, and then we use robotics here. So minimally invasive surgery, minimal scarring, typical 3-day hospitalization. We're working on 2. So no long-term medication. The donors always want to know if they need, immunosuppressive drugs after surgery too, and I always think that that's interesting, but it does make sense that they don't understand, exactly what's going on. Right now we're mandated to follow up for 2 years. I think that we're going to be mandated for even more follow-up in the future. There's a big push in the media and nationally right now on donor safety, and that in particular, especially since transplant people are in control of the donor process, that sometimes we may be more concerned about the organs than the donors. And a lot of donors felt abandoned, and this is nationally, not here, but felt abandoned after they donated a kidney because all they wanted to do, we're like, great, you gave us what we needed, so onward. So there's a big push both with CMS and a lot of things. You can also Google kidney donation. There's a bunch of fascinating websites telling you a lot of bad things about kidney donation. There's one called Kidney Transplant or Kidney Donation 101, and about things like NPR had one about chronic pain after donation, adrenal gland problems after donation, and a bunch of other things. So I think as a community and as an institution, we have to be very cognizant and be careful with our donor follow-up and make sure that the donors really are feeling that we are interested in their health, which we are, of course. So we do follow them up at 1 week, 6 weeks, 6 months, 1 year, 2 years. Right now, Marina Parker, who some of you may have met, is our nurse practitioner who's doing all the follow-ups, and I get involved if there are any problems. But at 6 weeks, they should be able to resume a normal lifestyle. There are no activity restrictions. There are no long-term medications. They should be able to go along and live their lives. Now, do I recommend that people jump out of planes? Not necessarily, but they should be able to do anything else. So here at UCSD, we're currently doing robotic surgery. Here's my little spiel about why robotics is better than laparoscopy. If you think about laparoscopy, you inflate the abdomen with air, and then you have small incisions and a small camera. So the laparoscopic instruments, for those of you who've been in the operating room, are like operating with chopsticks. You just have these big sticks that go like this. So what the robot does, the robot's more of a marionette than it is a robot. And instead of those sticks are attached, to the robot machine, and all of a sudden they have wrists. And those wrists are controlled by us as surgeons, at a console next to the robotic machine. And what it gives us as a benefit over just plain laparoscopic surgery is the ability to operate like we do when we're operating open. We can go around corners, we can see things, we can get to the difficult spots. And what we've seen here is that we're having a decreased risk of complications. We are better able to control bleeding or other complications that happen because we have a finer dissection, and we're able to suture easier and do other things easier. And we're also getting much better kidneys for the recipients. Our blood vessels are super long. They're almost like deceased donor kidneys because we're able to do a much finer and more detailed dissection. And again, anybody who wants to come and watch, we can work it out because it really is a fascinating procedure to watch. In the future, we're hoping to do some notes here. So, oops, I keep doing that, don't I? So here's what the robot looks like for those of you not familiar with it. So this is the robot machine. These are the arms that go in. We do always have a surgeon or two surgeons or surgeons and assistants all scrubbed in at the patient's bedside in case there's anything that needs to be opened or anything else. The operating surgeon sits at a control panel and manipulates with the control panel. So benefits, complex movements, improved dexterity, reduces surgeon fatigue. It is lovely to sit down and operate. If you could only have a little coffee cup on the side, it would be great, but no such luck. We can't have coffee in the operating room. Improved visibility. We actually see 3D and 12 times magnified. The visibility through the robot is fantastic. Better camera control, stable retractor, so the run of the robot arms actually does the retraction, so you're not dependent on the medical student who's doing this, during the case and falling asleep. So enhanced suturing, better vascular control, and the future, this is the future. This is where we're going to be sitting in offices doing kidney donations in other countries. This is amazing technology. So, and again, this is like I was saying, the robot instruments are like my hand. So a little bit about some other things that we'd like to do here in the future, for women who are interested in cosmetics to either do single port, and now we have a single port robotic surgery that's being developed right now. And then notes, and again, this is probably is going to be entirely for women, but people have done notes. So NOTE stands for natural orifice surgery. And so it's taking things out of the stomach, the rectum, the vagina, so that you don't have incisions. And this is really the future of incisionless surgery. Dr. Horgan pioneers this here at UCSD and actually pioneers it in the country and the world. He's done, I think, about 80 NOTES procedures right now, including appendectomies, removals of cysts and other things, where he takes them out through the stomach. Or through the vagina, and people not here at UCSD yet, but in the future we would hope to take a kidney out, through the vagina in a patient who didn't want a big incision. So it's all the possibility. Believe it or not, it doesn't damage, the vagina that much to have things go through. I mean, babies go through. So if you think kidney's a lot smaller than a baby, right? So it sounds terrible, but it's not as bad as it sounds. All right, so a little bit more, and then I'm going to show you a video at the end of the robotics, but a little bit more about things that we talk about in kidney transplant. So first of all, paired donation and kidney donor chains. This is a picture from People magazine, and these are all a chain of patients who donate and receive kidneys from each other. So paired exchange is where we try to take a pair that doesn't match and rearrange them to match with another pair that doesn't match. In the easiest way, it's with the blood types O, A, and B, like you can see here, blood type A to A, O to B, and B to B. The reality is that just doing paired donation based on blood type alone is a losing proposition, because most of the unmatched pairs are O recipients who have A and B donors, and they all need an O donor. So you end up with a glut of sort of the same mismatch. But where this has become more useful is with antibodies. If you have a blood type match donor, but say you're a daughter donating to your mom, and your mom has a bunch of antibodies to you because you were there, she gave birth to you, that with the antibodies they can't match, but then they can go ahead and do the paired exchange with somebody else who doesn't have antibodies. So the antibodies actually make this more of a reasonable thing. But still, there's a limit to it, and even if it's estimated that even if we had such a computer program where everybody in the US could be matched with a potential donor, we'd only increase transplantation by maybe 2 to 5%. But it's still better than not increasing it. So domino exchange is the other reason. These are how the chains get started. So this is where an altruistic or a Good Samaritan donor starts out a chain, and they go to the first recipient, and then their donor goes to the second recipient, and their donor goes to the third. And this can actually extend out, and then when you look at these chains, they get very complicated because there are other people who come into it and other pairs, but you can actually get these out 60, 80 people across the country. And that's where these chains have come in. So this is from the People magazine too. But you can see this guy just wanted to donate a kidney to somebody, donated to her, her husband donated it to this patient's donated to that patient, and then it went on. So it's pretty cool. Right now, there are multiple national programs. Unfortunately, UNOS has been a little bit slow. UNOS is our United Network of Organ Sharing. They're sort of the national organization that controls organ sharing. And they've been a little bit slow in getting a national program. So right now, there's a variety of different programs that you can join to try to get into these groups. We're part of one program. We haven't done our first transplant yet, but we're getting everything ready to hopefully do it soon. This is my last kidney transplant side, so.